So the importance of EKG synchronization, ECG-gating, the importance is that we need to have the dimension during the systole, which responds mostly to the 22 to 40% of the cardiac cycle, because this is the period where the dimensions are the maximum. And you can see from this imaging study data from Leipzig that you see in the systole, the perimeter is 77.4, in the diastole is 72.7. So if you miss this thing, that whether the dimensions are taken in systole or diastole, there is a chances that maybe you will be undersizing your valve, and that can create a trouble. And trouble will be sometimes your valve could be large than the annulus. It can cause an annular rupture. And at times, which is very much avoidable if you read the CT well, is that embolization, paravalvular regurgitation, all these can be avoided if you accurately size your annulus. And as I said, that alternatively you can use a 3DT, but yes, there is a chance of underestimating the valve dimensions. So better go for a, wherever possible, prepare your patient for a good CT and get it done. Peripheral vessels, we all know that data shows that the trans-femoral TAVI is safe, even in low-risk patients. Alternatively, if you go for alternate access, whatever it is, if you compare in a low-risk subgroup, we don't have data to suggest that you should go for low-risk TAVI through alternate accesses. So trans-femoral TAVI, this is what we want, and the data is the safest and the most best outcomes comes if you are able to do a trans-femoral access. And for that, CT becomes important. So how can imaging help TAVR planning? So it can give us an idea about what to expect. You can have your plan A, B, C ready, that what difficulties you can have. But what is more important is that it can, if you do it very well, analyze it properly, you can avoid a lot of things. You can avoid a root rupture, valve immobilization, paravalvular leak, coronary occlusion, access vessel injury, and it can predict the complexity so that you can be ready with your snares and everything. You can reduce the patient-process mismatch, reduce the incidence of stroke, and on follow-up also, we know that CT has a role because you can detect early valve degeneration by CT imaging. So coming to which valve based on your CT analysis. So first of all, the size is important, and then which valve to choose, whether a self-expanding platform or a balloon-expanding platform that can be used in this case. So that can be very much be decided on the CT finding. So we can decide about the valve sizing. So there is a rule of thumb that if you are going for a balloon-expandable valve, the valve should be not more than 5 to 10% oversized if it is balloon expandable. For it is a self-expandable platform, the valve sizing should be not more than 10 to 20% oversizing. So that is a thumb rule if you're choosing for a balloon expandable or a self-expandable platform. And definitely you can anticipate the rest. So this is, let's go by some cases, and definitely today we also can do some analysis of the CT. We can go and see the membranous septum because we know there is a very clear-cut relationship between the aortic valve and the conduction system. And this is where the conduction system lies, along the membranous septum, and that corresponds just inferior to the right and non-coronary cusp. So if the membranous septum is of decent length, like 6 millimeter or more, the chances of the device, implanted device interfering with the conduction system is least, and the chances of valve post-deployment PPI is least. But if the membranous septum is very small and your implantation depth is deep, you can expect some post-implantation chances of permanent pacemaker. So this is the relationship. So let me take you to some cases of mine where we have done some interesting analysis and how we approach the decision making. So here is one case, and you can see very well that it's a bicuspid Stevens type 1 valve where you have a RCC and NCC fusion, and you see very calcific valve, and the calcification going deep below in the alveoli. So a very calcified valve, and the perimeter derived area is 81.3, and the alveoli perimeter is about 85.5. Our sinuses are decent size. The coronary height is good, so any height above 10 millimeter is considered relatively safe. So I'm using the word relatively because it all depends how lengthy the leaflets are. The chances of having coronary occlusion in a bicuspid anatomy is more because the leaflets are asymmetrical, and even if you have a good coronary height, if the leaflets are bulky and lengthy, it can very well occlude the vessel, particularly if the sinuses are compromised. But thankfully, in this case, you see the sinuses are good, 35, 32, 35, and decent coronary heights. And if you see here, according to company's IFU, so in this case, what valve to choose? So in a very severely calcified anatomy, going with a balloon expandable becomes a little challenging because you don't have a control about how it expands. The advantage with a self-expanding platform is that it can conform with the contour. In a bicuspid aortic valve, instead of being circular, the supraannular contour is more of an ellipse. So it's better that you use a bicuspid, in a bicuspid anatomy, you use a self-expandable valve, particularly if you have an alveolar calcification. But what size to choose? So if you see 81.3 is the annulus perimeter, and according to the company's IFU, you can use a 29 millimeter valve. So whether you should go for a 29 millimeter or you do a undersizing. But in this case, you see our challenges are not much. You have a calcification, but you have alveolar dimension, which is pretty much sufficient. So in this case, we use a 29 millimeter Evolute Pro, and you can see here, because of the non and right fusion, the valve just shifted to the left sinus, and look how horizontally it lies. And post-implantation, there was 0 gradient. This patient was a very high-risk patient. Rheumatoid arthritis was there. He was on steroids. He made it well. He's doing fine.